So let's start with a 5-minute rewind. And what I want you to do is to think back to the previous video and I want you to walk yourself through the barrow reflex. So, what happens with the reflex when we begin to exercise? So, we had this awesome flow chart that was looking at when we sense a drop in pressure, what happens? What messages, where are these messages being read? Where is it being sent to? And what are the effects of that on the parasympathetic system and the sympathetic nervous system? So be specific and draw a flow chart out. And then I also want you to think about what effect does exercise have on the following things? And what is the physiology behind that change? What causes these changes? So when we begin to exercise, what happens with our heart rate and why does that happen and how does that happen? Same question for stroke volume. And then also for our cardiac output. And then going back to that barrow reflex, what's happening with our blood pressure? And mainly we have already talked about with our systolic blood pressure, but I want you to also think about what's happening with our diastolic blood pressure and our mean arterial pressure and see if you can take a guess on what's happening with these different blood pressures as we go from rest to exercise. So pause the video here and make sure you are on board with all of these different concepts or go back and rewatch the previous video so that we are not leaving you behind. All right, so in talking about cardiac output, we finished the last video talking about cardiac output and how much cardiac output there is. But now what we're going to do is talk about where is that cardiac output going and how exercise can change the destination of all of this blood flow. So at rest, about 20% of our cardiac output goes to our muscles. It's only about 20%. It's not a large amount, right? During, though, exhaustive exercise, close to about 90% of our cardiac output is delivered to our working muscles. So it's being redirected from other places, as well as increasing the amount of the cardiac output. So here, just taking a look, this is our oxygen uptake. So this is how much workload we're doing, how much oxygen we're uptaking going from resting up to a VO2 max. And this is our cardiac output and where it is going. So, about 20% of our cardiac output is going to the muscles. Our organs, our viscera, is getting this larger amount, right? The heart and brain, it pretty much stays steady from when we are at rest to when we are exercising. And then our skin has some interesting compensations as well. Our skin gets relatively little of our cardiac output, even though the skin is the largest organ we have within our body. As we move from resting to exercise, the way we see these things change. Muscle cardiac output goes from this 20% up to about 90%, right? So we get a large increase in how much cardiac output is going to the muscles. Right here to our organs, so like our kidneys and our digestive tract and such, that is an actual decrease. We don't need as much going to those areas, right? Because we are not needing to digest our food as we are trying to run away from whatever threat we have. The brain and the heart kind of stay pretty steady because we do increase the amount that's going to the heart simply because it is a muscle that's being worked. But the brain is kind of interesting in that it can't take larger volumes of blood because the skull doesn't allow it to because there's just not enough um, space literally for the blood to be able to increase in there. With our skin is relatively little at rest. However, when we start exercising, in order to deal with the increase in temperature in our body, we will actually vasodilate the arterioles within our skin to release more air to the outside environment instead of keeping it in. But then as we get up to max exercise again, we stop this because we just need to redirecting more blood flow to the muscles and to the respiratory system as well. So, the relative percentage of blood contribution to the heart stays around constant, around 4% of it, but the volume can increase about 5 times because we are increasing the volume of our cardiac output. The blood supply to the brain, the actual volume of it, is held constant because it can't allow for more blood to come into the brain because there's not enough space. The skull is restricting that. So, how does blood flow change during rest and exercise? We just took another look at it, but we're going to look at it in a different set of graphs to kind of give you a pictured representation of it. So, here we are moving from rest to light exercise to moderate exercise to maximal exercise. And this is looking at the percentage of our cardiac output. This is the same graph over here, but instead of the percentage, it's actually the volume of it, just how many liters per minute. And so taking a look at it, the brain right here, the percentage of cardiac output is around 10 per, I don't know, like 12% or so when we're at rest. And that percentage decreases over time. But when we look at the volume of it, the volume of this dark blue in the brain is staying pretty constant. So the same amount of blood is still going up to the brain. It just is changing the percentage of it. Here in the green, we have the heart. And what ends up happening is that we are staying around the same percentage of cardiac output as we move across from rest to maximal exercise. But the volume is increasing over time up to about 5-fold because of the more demand that we have. So the percentage stays the same, but the volume goes up. Now let's take a look at the muscle. So the muscle, remember, was only about 20% when we're at rest, and it can get up to about 90% when we are at maximal exercise. We are also increasing the volume of blood that is getting there as well. So to the muscles itself, we see that biggest increase when it comes to muscle delivery of oxygen. Here we've got the skin. So taking a look at the skin, it increases the percentage when we're dealing with exercise here, as well as the volume, and then drops off again at maximal exercise, as you can see there. Then with our kidneys, liver, stomach, intestines, that's where it normally is at rest. That's where our blood is typically going at rest as far as the percentage. But as we start to exercise, that percentage flowing there will decrease because it's not needed in those areas. It's still allowing for these areas to stay alive and to stay focused. So the volume is still sort of there, but it does decrease as intensity of exercise increases. But really, it's all shunting that or moving that to go towards the muscles, because that's where we're needing to get blood flow in order to bring oxygen and then also clear out any of the waste products that are produced through metabolism and activity. So we have a couple of different reflexes. We had the barrel reflex that will increase our blood pressure, our sympathetic activity, our heart rate, our cardiac output, all of those things, right? We also have what's called the muscle mechanoreflex and the muscle chemoreflex. So these are coming from the muscle itself. So we talked about with the barrel reflex, what's happening within the brain, right? But these ones are actually coming from the active muscles themselves. So literally contraction, stretching, and compression of the muscles will lead to the same effects of what we saw with the increase of our sympathetic activity that we saw with the barrel reflex, right? So it's that same thing that we saw with the central command hypothesis, in which when we're sensing this drop in pressure, we get the increase in the sympathetic activity and the withdrawal from the parasympathetic activity. This is also happening in response to literal contraction, the actual contraction, stretching, and compression of the muscles. It also happens in response to the chemicals that are released through metabolism when we are exercising, like lactate, hydrogen ions that are being released, these waste products that are building up because of metabolism when we are exercising, changes the chemicals around the system and in the bloodstream. And it also instigates that increase in sympathetic activity. So all of these things, the baroreflex, the mechanoreflex, the chemoreflex, are all systems that when we begin exercising will increase the sympathetic activity, and they act as backups to each other, because that's how important it is that we actually increase our sympathetic activity when we are exercising. So if one of these isn't working for whatever reason, there's disease in the body or an injury to the body or something's going on, then it uses these others as backup systems to be able to still produce the same results. So let's take a look at what's happening at the level of our vasoconstrictions. We talked about how when we are increasing our sympathetic activity, that we are vasoconstricting in the area. So what happens is that through our sympathetic activity, right, we are increasing our sympathetic nerve impulses. As those are increased, it sends messages through neurotransmitters like norepinephrine that will impact onto the blood vessels, right, to be able to vasoconstrict them. What it's doing is that it is taking blood that is in these unactive regions, such as like our kidneys and our digestive system and everything like that. And it's constricting it so there's not as much blood flow getting through to that area. However, when the muscles are working, we are getting a buildup of byproducts of the metabolism, like nitric oxide, prostaglandins, adenosine, ATP, potassium, hydrogen ions. We get an increase in our carbon dioxide and a decrease in our oxygen at the level of the blood right around where this activity is happening. So we have messages that are being sent from the brain that say we need to contract all of our blood vessels to be able to redistribute blood. But at the working muscle, we have all these local vasodilators that are saying, no, we need to get more blood flow to this area. So it becomes a balance between what our brain is trying to do and what the local area where the activity is trying to do. So what we can see is that these local dilators will actually go in and they will block these things from happening. So our endothelium is the layering around the edge of our blood vessel. It's like the outside rim of our blood vessel. This endothelium releases different things. This is nitric oxide as an example, but other things are being released like prostaglandins and adenosine and all of these different things in order to actually cause this vasodilation at the place where the muscles are working. So there's this competition that we've got these local vasodilators that are trying to get more blood flow to match the metabolic demand at the level of the working muscle. But we have the brain that's trying to vasoconstrict it. So it's trying to maintain blood pressure by vasoconstricting. And we've got these two competitions happening at the local muscle. Well, this is happening through what's called sympatholysis, in which what sympatholysis does, functional sympatholysis, is that it says functionally, in order to get our body to be able to move and still do this exercise, we need to break the sympathetic system at these local areas, right? To create this balance to make it so that we can still vasodilate to be able to get blood to the working area, but yet redistribute all the rest of the blood from other places to be able to maintain blood pressure and move it into our working area that we have right there. Now, the other component, we talked about cardiac output at length now, right? But the other component of our Fick equation is the arterial venous oxygen difference. Remember, it's that content of oxygen at the level of the arteries minus the content of oxygen at the level of the veins. So this is the difference between the amount of oxygen that's carried in the arterial blood and the amount that's carried in the mixed venous blood. So really, it's a measurement of how much oxygen extraction is happening at the level of the tissues. At rest, our arterial content of blood is around 20 milliliters per 100 milliliters of blood. That's in the arteries. In the mixed veins, so in the venous veins, what we're seeing is the O2 content is around 15 milliliters per 100 milliliters of blood. So that means that this extraction that is occurring is around 5 milliliters per 100 milliliters of blood, which is about 25% extraction happening because of the tissues. So at rest, we typically extract about 25% of oxygen from our blood to go to the tissues. During maximal exercise, the venous oxygen content can drop to about 2 to 5 milliliters per 100 milliliters of blood. So it widens this difference to about 15 or 18 milliliters per 100 milliliters of blood, which means we are now during exercise are extracting around 75 to 90% of the oxygen from the tissues when we're exercising. So let's just look at a picture of this to kind of get an idea. So venous blood is returning from the exercised muscle will have a lower oxygen content, right? So about 3 milliliters of oxygen per 100 milliliters of blood. This is the exercising oxygen, the muscles, because we were dropping off more oxygen to those working muscles. But blood returning from the tissues that aren't really active, like our digestive system, our kidneys and such, is really more like, around rest, which is around 15 milliliters of oxygen per 100 milliliters of blood. So these two bloods are mixing in our larger veins, like the vena cava. So we have the blood that's returning from the working muscle, having a very low oxygen content, blood that's returning from the non-working areas of the body, which is at a higher oxygen content, and these mixed together to become mixed venous oxygen content, around 5 milliliters of oxygen per 100 milliliters of blood. Right, so it's somewhere between those two different levels. Well, what happens is that we're getting this widening gap between the oxygen content at the arterioles versus the veins as we move up in our intensity of exercise. So the ability of our muscles to extract oxygen for a given amount of blood tends to be this limiting factor for maximal exercise with individuals who are regularly fit or sedentary individuals. So remember, we talked about cardiac output being this thing that limits elite athletes. They can't pump the blood around fast enough, but it's because they have grown more capillaries in the muscles to be able to extract the oxygen really well. If we are not trained in exercise, we are recreationally fit, or if we're sedentary, we do not have the extent of oxygen extraction at the working muscles that an elite athlete does. So this becomes our limiting factor for most people, is that we literally just can't pull enough oxygen from the blood because there's not enough places to be able to do that. We haven't built enough capillaries. When we start to exercise, one of the biggest things that starts to happen is we grow new capillaries to deliver blood to the working muscle areas. And that allows us to be able to extract more oxygen out of it. When we don't have these built up yet, we can't extract the oxygen as quickly or efficiently. So that was our cardiac output and taking a look at our AVO2 differences. But let's talk a little bit about blood pressure response also when we are exercising. So the mean arterial pressure. So when the mean arterial pressure is defined as taking a third of the difference between the systolic blood pressure and the diastolic blood pressure and adding back in the diastolic blood pressure. So it's taking a third of our pulse pressure and adding back in our diastolic blood pressure. On average, it's around 90 when we are at rest, and that's for a blood pressure of 120/80. It's also can be conceptualized as what is our cardiac output times the resistance that it needs to travel through in order to get there. So that's our total peripheral resistance that we have there. Well, we know that as we start exercising, we will get an increase in our systolic blood pressure. We get that vasoconstriction that's happening because of the increase in in the sympathetic activity that's occurring when we begin exercise. Our diastolic blood pressure can actually stay the same or start to drop a little bit because of the massive vasodilation that we have at the level of the working muscle. So, when we are working at higher amounts of intensity using larger muscle masses to be able to do that, remember those local vasodilators that would come in and dilate the blood vessels, they are helping us to decrease that diastolic blood pressure as a result of that. So when we get to mean arterial pressure, it tends to follow up with our systolic blood pressure, right? Because the systolic blood pressure is increasing exponentially compared to the diastolic blood pressure. So you'll see that mean arterial pressure go up as well. Now, just as a note, and this is something for us to know as exercise professionals, if we're ever in a lab setting and are measuring blood pressure as somebody is exercising, that if they experience a significant drop in their systolic blood pressure, like more than a 10 millimeters of mercury amount of it, this is grounds for stopping of exercise because there is something at risk with their blood pressure dropping during exercise. Systolic blood pressure increases in proportion to the workload, mainly via that rise in cardiac output. So we usually get an increase of about 8 to 12 millimeters per mercury per MET that we are exercising. Total peripheral resistance, however, is decreasing with exercise due to those local vasodilators of the active muscles. So the diastolic blood pressure stays fairly steady or can even drop slightly with exercise. Then our pulse pressure, the difference between our systolic blood pressure and our diastolic blood pressure, therefore will increase in parallel with systolic blood pressure and workload, because we can see this difference of the exponential raising of that systolic blood pressure. Lastly, I just want to end us on some chronic adaptations of what happens when we have been exercising for longer periods of time and are more trained and fit individuals. So, what we're doing here is taking a look at what are the differences between somebody who is sedentary versus somebody who is endurance trained, and what are these different variables doing while they're at rest, submaximal, or maximal exercise from measurements before they were trained versus after they were trained. So, a person who goes from not being trained to being an athlete, when they are at rest, oxygen consumption, there's no change. Same with no change in their submaximal exercise. Because remember that everything that is happening with our oxygen consumption is just linear up to matching the workload. But what we can do is we can go for higher workloads when we're more trained. So our maximum oxygen consumption will increase between when we were sedentary versus when we were endurance trained. Our heart rate when we are resting, because of adaptations and health of the heart, we will actually decrease the heart rate. So we lower the resting heart rate as a response to being endurancely trained. It also lowers our heart rate for any given level of exercise. Up until max, we don't really see a change because we can't really change our heart rate. It's based on your age more than it's based on anything else. So we really don't see any kind of a change. Stroke volume. Stroke volume at rest will be increased when we are endurancely trained versus when we're sedentary. That will also happen at our submax exercise and at our maximum exercise. So once we become more endurancely trained, we get an increase in our stroke volume across the board at all different types of activities. With our decrease in heart rate, but increase in stroke volume, what ends up happening is that there's not much of a change in cardiac output. Remember, those two variables are what go to contribute to cardiac output, and they balance each other out at rest. Same thing when we're experiencing our submaximal exercise levels. However, because we had the increase in stroke volume, we will see an increase in our maximum amount of cardiac output as we go from being sedentary to being endurancely trained. As far as blood flow to the working muscle, we are able to actually increase the growth of capillaries, our capillary density, going to the working muscle. At rest, we don't really see any changes because we're not needing more oxygen going to those different areas. So the blood flow isn't really going to the muscles. It's still at around 20% of our cardiac output. But when we start exercising, we actually can deliver blood better because of those increases that we've built more capillaries in our system. And so also at max exercise, we will see that. As far as our breathing, we're going to get into breathing in a little bit later, but we don't really see a change in how much we're breathing at rest. However, when we are exercising and we are more fit, we will have a decrease in our respiration rate. And then we get an increase at our maximal rate, so we can actually intake more oxygen. Here was our AVO2 difference. So this is the difference of content of oxygen in the arteries versus the veins. It's the second half of the Fick equation. At rest, there's no change between this. When we are exercising from when we were sedentary to versus when we are endurancely trained, we will see a slight increase in this difference and an increase at maximum exercise. Our lactate levels, there's no change at rest. During submax exercise, there's a decrease in the buildup of lactate because we have pushed our aerobic exercise into different levels before we move into anaerobic exercise again. So we've improved our ability to create energy out of the oxidative metabolism system as we increase our VO2. And then how much we can produce of lactate at maximum exercises increases as well. So take home messages of what I want you to understand is that our VO2 peak or our VO2 max is improved because we get more oxygen and can have more extraction when we move from being sedentary to when we are endurance trained. The resting heart rate is reduced because we will have an increase of our parasympathetic nervous system control when we are at rest and an increase in our stroke volume. The stroke volume increases because of our heart size, the contractility of how much it can pump out, and we also get an increase in our plasma volume. So literally our plasma or the blood volume we have will increase as well, which increases our stroke volume. And a lot of our cardiac output increases are coming because of these increases in stroke volume. Some more chronic adaptations to exercise. We increase blood flow to the active areas, to those working muscles because of growing new capillaries and being able to direct blood flow into better areas. So this is somebody who is normal, sedentary or recreationally active versus when they become conditioned and looking at blood flow. And literally we can increase the amount of blood flow after we have been successfully trained for a long period of time. Remember this chart when we were taking a look at our oxygen content? We start to be able to actually extract more oxygen from those capillaries that are being delivered. So blood that's returning from the exercising muscle, instead of being like around 3 milliliters of oxygen per 100 milliliters of blood, it actually can be reduced to about 2 milliliters of oxygen. So we're extracting more oxygen. When that combines with the blood flow that's returning back from the inactive tissues, the overall of our oxygen content, or the AVO2 difference between our mixed venous blood, you'll see that we actually will decrease the amount of oxygen returning back in our mixed venous blood. So the resulting mixture of the blood will have a lower O2 content in our trained individuals compared to our untrained individuals. So it ends up being a greater AVO2 difference. Other chronic adaptations that happen when we are endurance exercise trained. We increase our myoglobin content, the proteins within our blood, which aid in oxygen delivery muscle to our mitochondria. So we can actually increase our myoglobin. That's helping us to be able to deliver oxygen to our mitochondria in our working muscles. We increase the volume of our slow twitch fibers. Remember those oxidative muscle fibers. So those can happen over time. Remember, trying to get our increase in our slow twitch fibers to be able to last for longer periods of time. We do get a reduction in our blood pressure if we start off being hypertensive. It doesn't really work as a decrease if we are operating in normal blood pressure. But if you are already slightly higher in our like a pre-hypertensive blood pressure, beginning an exercise program over time will help to reduce that resting blood pressure. We begin to thermoregulate better. We can actually control our temperature better as we exercise more. We get an increase in our HDLs, which are our good kind of cholesterol, our high density lipoproteins, and a decrease in our triglycerides, which is a marker of cardiovascular risk. We get an increase in our lean body mass and a decrease in our body fat. We get a maintenance or an increase in our bone density, ligament, and tendon strength. So all of the structures in our body are becoming stronger. We get an enhanced self-confidence and independence. So especially, and I know if somebody's younger, they're not understanding this, but the more active and functional you can be in life as you become older, the better it is and the more confident you can be at being able to still take care of yourself in older ages. We also get a reduction in anxiety and stress over time with chronic endurance athlete or chronic endurance training. We also, as far as some of the more clinically significant changes, is we get improved functional capacity because we get more strength and endurance. So we can go for longer and for stronger and to be able to maintain daily active living appropriately. We improve our recruitment pattern and synchronization of our motor units. So everything becomes more fluid and more efficient. We get improved balance and coordination, which means we are decreasing our number of falls as we start to become older. We get an increase in our lean body mass and decrease in fat, as we said, and a maintenance of that bone density and bone strength. Transformation of those type 2 fibers towards the type 2As, the type 2Xs versus the type 2As. Type 2Bs are in animals, but type 2Xs are found in humans. So we get a conversion more towards those type 2As, and we get an enhanced independence and quality of life. So these are like, I realize if somebody is younger and they're not thinking about these things, it's hard to remember these aspects of it. But these are all things that can really impact what an elderly person can do in order to create independence for them long term so that people don't have to be taking care of them. One of the best reductions that we can actually see is in all-cause mortality. So as we move from sedentary to minimally fit to average to moderately fit to most fit, right? And we're looking at both men and women. When you are moving from being sedentary to minimally fit, you get a huge reduction in deaths. We don't see it as much when we go from minimally fit to the other categories as high, but we get a big drop from going from sedentary to minimally fit. So literally adding walking at night into your program or into a person's program can reduce their chance of death. That's a huge factor to be considered. So that shows you kind of the differences that what we see with the cardiorespiratory system or the cardiovascular system when we are exercising and what happens while we are in a bout of exercise and also long term over time. I hope that you learned something and I hope you enjoyed.